Perfect. Okay. So there was a few different use cases that the group had wanted to talk about, and I figured I kind of put a couple of them together and decided that we could talk a little bit about how we could actually measure the different components of the quadruple aim, and kind of really I've had this like little bug in my head for a little while about like how could we actually do like a pilot project with measuring the quadruple aim. So I wanted to kind of go through data elements, what that would look like, and at what level each of these elements would be measured at. And so the quadruple aim is really, improve patient experience, improve population health, improved care team well-being, and reduce costs. These are just some of the potential ways to measure them. These are kind of the things that I think about, but there could definitely be other measurement mechanisms. So for patient experience, I think a lot about patient quality of life, improved population health. We think about chronic conditions. It could be chronic pain. It could be diabetes, hypertension. Then we think about improved care team well-being. That's at the clinic level generally. Burnout, provider satisfaction, particularly in this time of COVID. We're seeing a lot of distress for obvious reasons among clinicians. So we always want to be mindful of that as well. And then reduce costs at the system level. And so in that respect, we often think of cost effectiveness, quality of life adjusted years, quality adjusted life years. So just kind of wanted to lay out the different levels of measurement and some of the potential measurements. So we're going to have a case study to talk through. And so at the individual level, Kevin's a 38-year-old man with chronic lower back and leg pain. He was involved in a serious crash 3 years ago. He's had surgery by a local orthopedic surgeon. He was placed on PRN oxycodone. He is taking 15 milligrams 5 times a day. And I also wanted just to put in parentheses that that's, 112.5 MEDs. The patient population that's generally considered at risk is, one of the factors anyway is having greater than 90 MEDs, which is a morphine equivalent dose. He reports fair pain relief, but is unable to continue working as a long haul truck driver. And I modified this from a case study at the Pennsylvania Medical Society. So we also want to consider, though, the practice and system level, because we're talking about the quadruple aim. So given the prevalence of high-risk opiate use in the population, a multimodal interdisciplinary approach to treatment is implemented, and all facets of the quadruple aim are measured. So this is a hypothetical situation, but let's say that at a system level, they decided to implement a program where instead of only prescribing opioids, we would do like physical therapy, lifestyle change, mental health services, occupational therapy, have nutritionists available. So we were looking more holistically at the patient, and then we would also do provider training around compassion fatigue and distress. So in this case, we're not dealing with, things like COVID-19, but some of the most difficult patients for providers to manage are chronic pain patients, because there just doesn't seem to be any relief for them. And it kind of becomes this really bad, cycle of pain and depression and anxiety and additional pain. And lots of times, long-term opiate use isn't actually resolving their pain anymore. So there's a variety of quality of life measures. One of them that is pretty common, though, is the health-related quality of life which is a measure that the CDC uses. So the HRQOL is scored as healthy days, both physical and mental. So essentially it asks patients in the last 30 days, how many days did you feel physically unwell? And the same thing with mental health. And so essentially what we would want to do is establish a baseline at the patient level and then continue to track them monthly and potentially quarterly later once we can see, hopefully a positive trend emerging. We could do this through patient self-report through electronic means rather than them having to come into clinic all the time, which obviously with COVID now definitely isn't as possible, but even before having a patient come in every month just to, fill out a survey or whatever that might be, just feels overburdensome. So once we establish any kind of trending, then the treatment modality for that individual patient could be modified based on their physical and mental healthy days. We might find that they really need more mental health support than physical health support, or vice versa. And by the way, please stop me if there are any questions. All right, so improving population health. How do we measure improvement? Quality adjusted life years is an index between 0 and 1, with 1 being a year of perfect health. Most of us probably don't actually have what's called a QALY of 1. However, hopefully we're definitely far away from the 0 side of it. So what we want to look at with population health is the percent of adults with a disability or mobility problem decreasing over time. Or with mental health, we could look at the percentage of patients that score 10 or higher on a PHQ-9 decreasing over time. And then we could establish a baseline and measure quarterly or semi-annually within the population. And I apologize, this graphic didn't come up very well on the right here, but care team well-being. One of the instruments that we recently used for training was this professional quality of life, which I really liked because it kind of looks at a few different aspects. It looks at how satisfied a practitioner is from a compassion perspective and from work-related perspective. So how satisfied are you with the work that you're doing? But it also looks at compassion fatigue. And so burnout and secondary trauma that they're experiencing from working with patients who, have had difficulties that might be chronic disease. It could really be anything. Right now, COVID, of course. So obviously, it's of particular concern during this pandemic. In this use case, though, as mentioned before, it can really become difficult for providers to work with these patients that seem to have intractable pain and, really have difficulty seeing hope on the other side. So we could establish a baseline again, and it might be high currently just due to COVID. So in a case where we're not looking at COVID specific, we might need to make some adjustments. So let's say we were starting this study right now and we were establishing a baseline. We might need to really caveat and think about the fact that provider burnout and secondary trauma is probably relatively high right now. And that might not be the true baseline in normal conditions. And that's okay. I think we just always need to keep these things in mind. And then cost effectiveness. So reducing healthcare costs is critically important to maximizing health services with constrained resources. So cost effectiveness is a common measurement when we're comparing treatment protocols. So let's say in this case, we would compare business as usual. So kind of what we're doing today to the new multimodal treatment protocol. So measurement in this case, though, shouldn't be monthly or quarterly. It actually needs to occur over several years, because we might see initial costs higher, but total cost for care over years or over a lifetime could be significantly improved. And this also brings up one of the issues that we deal with a lot in clinical, well, this isn't a clinical trial, but when comparing treatments, is if we have a population of 1,000 patients, let's say, due to them moving or just not being engaged anymore with the study, we end up with loss due to follow-up, which means that we're actually losing information about that patient. So there's statistical methods that handle that. And I won't get into the weeds about it at all, but kind of think about that as we're talking about some of the methodology, which we're going to do next. And that's probably a pretty natural place to stop and ask if there's any questions. Okay, hearing none. I kind of wanted to write out a few research questions just so we can think about what this would look like if we were trying to pilot this. So, will patients who suffer from chronic pain with long-term opioid use and depression who are given alternative treatments have lower total costs and better outcomes? We would think that both of these things would be true. So as long as we're careful about how frequently we measure using validated, appropriate measurement tools, then we can answer a lot of these questions. And then we also want to look at opioid naive patients. If we haven't actually started them on, long-term opiate therapy, can we kind of nip that in the bud, so to speak, before they even start walking down that path, and give them alternative treatments, which will improve outcomes, obviously lower costs, and significantly improve their quality of life, because now they don't have the potential for opiate use disorder. And also, will providers who treat complex patients with chronic pain have lower levels of burnout as the population health improves? So, well, of course, we're interested in patient improvements. I mean, as clinicians, as human beings, I think we all want to see people suffer less. Unfortunately, with the system, we do need to find ways to also save costs, or to show that even though there's not a cost savings, there's enough of an impact from an improved quality of life that it can be justified. So we're kind of developing a business case in a way. So we're saying, okay, these are the methodologies that we're going to use to help patients, providers, and the outcomes are really going to be beneficial to the system and the population. So, we're going to define patients with long-term opiate use, those that are greater than 90 days. Opiate naive patients would be patients who have not been on long-term opiate therapy before. And essentially these end up being our hypotheses. So we have our research questions, and here we're saying what our hypothesis is. So we're saying that we believe that they'll have fewer symptoms, and that there'll be a lower total cost of treatment over time, and that providers are going to have an improvement in satisfaction and less distress, which would also lower turnover, we hope, right? So if we can help patients, help providers, improve population health, lower costs, then we've met the quadruple aim. So I'm often asked, why do we need to go down the path of doing a statistical test? Why do we need to, can't we just compare costs before and after and just say, oh, well, that cost is lower, we're good to go? Well, the problem is that it could just be due to chance. There could be other things going on that are kind of confounding the analysis. So statistical testing allows us to show that the improvements were actually due to the program, not just a chance. So sometimes we can't, we don't have the right data elements. We don't have a large enough sample size. We haven't followed them for long enough. And that's okay. We can do pilot studies or evaluations, but truly the gold standard is really being able to say that this difference is statistically significant, and therefore it was directly due to the program. I had mentioned earlier that we run into censoring issues with when we're looking at prospective studies and we lose patients to follow-up. We know that their information is truncated, but the information up until that point is still very valuable. So in traditional regression, any observation, so any person who had missing data elements, the regression actually just removes that person from the population, and it doesn't handle missing data. There is, however, methodology that does, and just as an aside, my advisor when I was at Texas A&M developed some of this statistical methodology, and I later wrote the code to implement it in Stata, which is a statistical software company. So the methodology was developed in the early 2000s. It's been used for a variety of use cases. I think the most recent was related to defibrillators for people with specific heart conditions. But you can essentially think about it as anytime you want to look at cost effectiveness and patient outcome, you can use this methodology. And I will say that we're actively pursuing adding quality of life measures to the command as well, so that we now have, at least 3 of the components, right? We have a cost component, we have a population outcome, which we can also look at individual outcomes because we have individual level data, and we would have quality of life. So the other component that we would be missing just in this routine is at the provider level, but that's okay because it doesn't necessarily fit in there, so we can do additional analysis at the provider level. So here's just an example of what we would hope that we would see from healthy days, physical and mental unhealthy days, like over time. So Kevin's healthy days have increased from 9 to 22 after 6 months, and then his unhealthy days, both physical and mental, have decreased as well. The pro QOL, so the professional quality of life, so the thing is that satisfaction is kind of measured on the reverse scale, right? So higher levels of satisfaction are good, so it's green, and then burnout, of course, higher levels are bad, and same with traumatic stress. So I just kind of color coded this to emphasize that it's on a reverse scale. So in compassion satisfaction, we hope goes up after we've given them some tools and resources and training. And then we hope that burnout and traumatic stress go down, again, after we've helped them with some coping mechanisms, and other training materials. And we also hope that that improvement is sustained over time. So it is important to follow up, maybe at 6 to 12 weeks, again at 3 to 6 months, and just really kind of see if the coping skills that they've learned and all of the materials have stayed with them, or if we need to do a follow-up training. Okay, and so that was at the patient and provider level, and now we want to look at results at the population and system level. So I was talking about the routine measuring cost and like time to recurrence. So in this case, it's chronic pain. It could be, I mean, it really could be anything. You know, a lot of times we might even look at, you know, the outcome of patient death in cases of cancer trials or whatever it might be. We were doing work some time ago on Huntington's disease, which unfortunately does not have a good outcome. So we could look at the difference in time to death or time to recurrence of symptoms. In this case, we're considering time to recurrence of significant pain, let's say. And so we have these two like quote unquote competing treatment protocols now, right? We have the business as usual and then the new multimodal treatment protocol. And so note that I kind of highlighted the p-values here because they're both significant. Anything less than 0.05 is generally considered significant for a 95% confidence interval. Sometimes people use higher levels of confidence, but these p-values still meet that criteria. And so essentially what this is saying is that the average cost savings for the treatment group was $2,798. So the folks that were in the new multimodal treatment, you know, we saved $2,800 per, and the time to recurrence of their, you know, their chronic pain symptoms, so significant pain, was 245 days. So we've given them 8 months of relief and saved the system $2,800 on average per patient. And so the incremental cost effectiveness ratio isn't super meaningful in this case, but essentially we saved the system $11 per day per patient. So it's really just savings over days impacted. So if we wanted to really look at a much more microscopic level, I guess, we could say that, you know, per day we saved X number of dollars. And then you can make the argument too that as you scale that up, going back to thinking about our business case, as you scale that up, what can you really save at the system level? And I seem to have gone through that quicker than I thought, because usually I plan on 30 minutes. So any questions? Any thoughts? Was it interesting, helpful?
I think that that's really good information. I think that the folks that we have on the phone